So I'm an epidemiologist at Georgia Regents University Cancer Center. My previous work mostly involves lifestyle risk factors and biomarkers related to breast cancer, possibly through inflammation pathway. And obesity is one of those factors. Today I'm going to present epidemiological data suggesting the link between obesity to breast cancer risk and breast cancer outcome, and also proposed mechanism, particularly focusing on inflammation. And I will also touch on some intervention strategies to reduce the impact of obesity-driven inflammation in breast cancer. I'm an epidemiologist, so I'll first start with some of the breast cancer statistics. Breast cancer is the most common female cancer in the world, with nearly 1.7 million new cases estimated in 2013. This represents a quarter of all female cancers. Breast cancer has increased in recent decades, particularly because of an increase in developing countries due to a shift in lifestyles. But breast cancer is still much higher in developed countries compared with developing countries. And in terms of age standardized rate, United States is ranked in 9th place, following some of the Western European countries like Belgium, Denmark, among others. This is the SEER cancer registry data collected from 9 areas across the United States, including metropolitan Atlanta area. The red line indicates breast cancer incidence per 100,000 women, and the blue line indicates breast cancer death. And as you can see, breast cancer incidence increased until 2000, and between 2002 and 2003, there is a drop by 7%, and this is largely due to the result from Women's Health Initiative trial. This is a randomized controlled trial of a post-hormone replacement therapy, and what this study found was not just breast cancer risk, but also cardiovascular diseases risk is increased with the postmenopausal hormones. Since this result came in, the use of hormonal replacement therapy use has dropped consistently, and now it's just less than 2%, and this is thought to be a major contributor to the larger decrease in breast cancer incidence. Since then, breast cancer incidence has remained stable, and with about 120 new cases per every 100,000 women in the United States. Breast cancer mortality was kind of stable until 1990 and has begun to decline in those years. And this is thought to be due to early detection or increased awareness as well as improved treatment. Several risk factors for breast cancer have been identified, and some of the risk factors cannot be changed, such as older age, female, or some of the inherited genetic characteristics. For example, women with BRCA1 or 2 genetic mutations have more than 4 or 5 times lifetime risk of increase in breast cancer compared to those without those mutations. And some of the other genes has been also identified, but those genetic mutations are much rarer compared to BRCA1 or 2, and its impact on breast cancer is relatively minor. Estrogen has been a major player in breast carcinogenesis, and some of the factors such as early menarche or later menopause has been associated with a slight increase in breast cancer, and it is thought to be due to a longer exposure to circulating hormones. On the other end, having multiple children, and earlier age pregnancy and breastfeeding for more than a year has been associated with the protective factor for breast cancer. You may argue that these pregnancy-related factors are modifiable, but they are not amenable to change in reality. More malleable risk factors for breast cancer include use of oral contraceptives and hormone replacement therapy. But the good news is the risk elevation associated with these pills appear to go back to normal over years once pills are stopped. And as little as 2 to 3 years of physical activity, such as 2 per week, 2 2 to 3 hours of brisk walking per week has been associated with reduced risk of breast cancer risk, whereas excess weight after menopause and alcohol drinks increase breast cancer risk. And for smoking and dietary exposures and also environmental chemicals have received a lot of attention as a potential risk factor for breast cancer, but no, there's no convincing evidence available yet at this point. But healthy diet is closely related to weight management, so there are multiple other reasons to promote smoking cessation and healthy diet. With that, let's look into the relationship between obesity and breast cancer. So for surveillance and research purposes, obesity is commonly defined by a body mass index, which is an index of weight adjusted for height. BMI is simple and it's well correlated with gold standard measures of fat in adult population. And validity of BMI has been supported by some of the studies showing its clear association with other risk factors for obesity-related risk factors such as blood pressure or serum cholesterol or glucose levels. And according to WHO and HLBI classification, BMI of 18.5 through 25 is defined as normal weight, and BMI of 25 or greater is defined as excess weight, and this is further classified into overweight or obesity class 1 through 3. And the graph next to the table shows age-adjusted prevalence obesity in the United States in the last few decades. There has been a dramatic increase in the prevalence of obesity around 1980. And in 2000, it reaches about 37%. And the good news is, in 2011 report, which became available recently, the prevalence of obesity remained quite stable, with still at about 37% of adult women being obese and 67% being overweight. There has been convincing evidence suggesting that obesity or higher BMI is associated with increased risk of breast cancer in postmenopausal women. A meta-analysis is a type of study that combines the results from multiple studies to identify a pattern. And according to a result from a meta-analysis of 34 cohort studies, so by cohort study I mean BMI was determined at the baseline, and then women are followed up for incidence of breast cancer. In this study, they found that obesity or 5-unit increase in BMI was associated with about 12% of increase in breast cancer risk in postmenopausal women, but it was associated with 8% decrease in premenopausal women. So the opposing association between obesity and breast cancer risk by menopausal status is thought to be related to the different sources of primary estrogen synthesis between pre- and postmenopausal women. In premenopausal women, so ovary is the primary source of estrogen synthesis under the cyclical control of pituitary gonadotropins. But on the other end, in postmenopausal women, the A, which is androstenedione, which is an intermediate hormone from adrenal glands or ovary, is converted to estrogen and then further converted to estradiol in peripheral tissues. So in postmenopausal women, obese postmenopausal women will have an elevated risk of breast cancer because of increasing estrogen biosynthesis in adipose tissues, fat tissues. But in premenopausal women, obesity may result in anovulation, so they have a less exposure to circulating estrogen and progesterone, which may increase or decrease the risk of their breast cancer. The different relationship between obesity and breast cancer risk by menopausal status also suggests that the relationship between obesity and breast cancer risk may vary also by hormone receptor status of breast tumor. And several studies have investigated this question, and indeed, among postmenopausal women, obesity was more closely related to hormone receptor positive breast cancer, ER positive or PR positive breast cancer, leading to about 40% increase. But ER negative or PR negative breast cancer, obesity was not associated with increased risk. In premenopausal women, the same thing happened. Obesity was associated with a decreased risk of hormone receptor positive breast cancer, but there was no clear relationship or risk decrease associated with obesity among premenopausal women for hormone receptor negative breast cancer. And particularly for triple negative breast cancer, which is subtype breast cancer not only lacks hormone receptor status, but also it lacks an expression of a HER2 marker. For triple negative breast cancer, obesity actually increases the breast cancer risk even among premenopausal women. So to summarize, obesity increases the risk of hormone receptor positive breast cancer, which represents a majority of breast cancer in postmenopausal women. And obesity may also increase the risk of triple negative breast cancer in premenopausal women. Triple negative breast cancer comprises only 15% of all breast cancer in younger women, but its risk is more than double among African American compared to other races. And moreover, triple negative breast cancer has been associated with a higher risk of distant metastasis and mortality, and there is no targeted therapy available yet. So the positive association between obesity and triple negative breast cancer premenopausal women is not something to ignore. And what about the effect of obesity on breast cancer survival? And here's the result from one of the largest study investigating this question. In this study, more than 50,000 patients with early stage breast cancer has been followed up on average 7 years. And during the follow-up, there were 4,100 local regional recurrent events and about 7,000 distant metastasis events. And you can see that there is no influence of obesity or different BMI on local regional recurrent event, which on the below section. But for distant metastasis risk, the risk started to separate after approximately 3 years. And then there is a clear trend of increasing risk of distant metastasis with increasing BMI. So the risk of cumulative incidence of distant metastasis at year 10 is about 24% for obese patients, but it was about less than 20% for normal BMI. And in the same study, obesity was also associated with breast cancer specific mortality and also non-breast cancer related mortality. So including that study, now numerous studies has replicated this finding, suggesting that higher BMI reduces overall and breast cancer survival. Again, this is a meta-analysis of 82 study that involves more than 210,000 breast cancer survivors. In this study, as you can see, the left on your right is total mortality, and on your left is the breast cancer specific mortality. And with increasing BMI, you can see the increased risk of total mortality. And you can also see the slight increase for the underweight woman. And this may be probably related to comorbidity associated with the severe diseases. And this creates a kind of J-shaped curve between BMI and total mortality, and this is more clear, the J-shape is more clear when BMI was measured at least 1 year after diagnosis. But we don't see the J-shaped relationship between BMI and breast cancer specific mortality. Increasing BMI was linearly increased the risk of breast cancer specific death. And this was regardless of the timing of BMI measurement. There are several factors contribute to increased mortality in obese patients. First, obese patients have a high rates of other diseases like hypertension, diabetes, or other cardiovascular diseases, which may reduce overall survival. And obesity may also affect treatment efficacy. Several clinical trials have shown that obese patients have poorer response to tamoxifen or taxane. And moreover, there is some evidence suggesting that physicians may empirically reduce the treatment dose because of the fear of intoxicity in obese patients. So obese patients may end up receiving less than optimal dosing of cancer treatment. And given that obesity disproportionately affects women in the lower socioeconomic stratum, there may be a confounding by different access to or quality of healthcare, as well as other behavioral factors associated with obesity and both socioeconomic status. And studies have also suggested that obesity also negatively influences treatment-related effects. Surgery is currently the mainstay of breast cancer treatment. And there is an evidence suggesting that surgery is technically more difficult in obese patients, and poor surgical outcome and longer recovery time has been suggested in obese patients compared to lean patients. And in general, obesity also has been associated with higher infection rates. And lymphedema is a chronic condition that involves the swelling of the arm because of the axillary lymph node removal of breast cancer patients. And obese women have more than 2 times higher risk of lymphedema after cancer treatment. And pilot study have suggested if weight loss may help with the lymphedema. And cancer-related fatigue is one of the most distressing symptoms among cancer patients. It really impacts not just the physical, but also functional and psychosocial, and just many aspects of the women's life. And cancer-related fatigue is very common in cancer patients, but it's particularly common in obese patients. And long-term fatigue, which lasts years after the completion of cancer treatment, is also much more common in obese patients. So with that, to summarize, obesity not only increases the risk of breast cancer, but it increases the risk of developing distant metastatic recurrence and reduces overall and breast cancer specific survival. And the relationship between obesity and survival does not vary by menopause status or tumor hormone receptor status. And obesity also negatively affects surgical risk and adverse effects of cancer and cancer treatment, such as lymphedema and fatigue. So what are the biological mechanisms that link obesity to breast cancer? Estrogen biosynthesis, increased estrogen biosynthesis, is a major pathway that explains the increased risk of breast cancer in postmenopausal women in relation to weight gain. But there are other mechanisms that contribute to the link between obesity and breast cancer. First, obesity causes insulin resistance, which is characterized by hyperinsulinemia and glucose tolerance. And high insulin has a mitogenic and pro-angiogenic effects, so it promotes tumor progression. And insulin also stimulates insulin-like growth factor 1 synthesis, and IGF-1 has been implicated in multiple aspects of cancer progression. Obesity also causes subclinical inflammation. During weight gain, adipose tissues are expanded, and this leads to recruitment of macrophages. And it is known that these macrophage and adipocytes release a variety of inflammatory cytokines and adipokines, and this contributes to systemic or local inflammation. And this has led to the recognition that obesity may be defined as a state of low-grade systemic inflammation. So activated macrophages release a variety of inflammatory cytokines, and this cytokine has been implicated in cancer growth and progression. For example, interleukin-6 has anti-apoptotic property, and higher levels of interleukin-6 has been associated with poor outcome in breast cancer patients. Adipocytes also release adipokines such as adiponectin and leptin. Obese individuals usually have higher levels of leptin but lower levels of adiponectin. And leptin has been shown to have a pro-tumorigenic effect, whereas adiponectin has an anti-cancer effect as well as insulin sensitizing effect. And so it seems that all these pathways are closely related to mediate the link between obesity and breast cancer. I have been particularly interested in the interaction between adipose tissue inflammation and estrogen biosynthesis in postmenopausal women. This is the macrophage, which is known to represent about 40% of obese adipose tissue. So NF-kappa B activation induces gene expression of pro-inflammatory genes. And closely-derived PGE-2 and pro-inflammatory cytokines induce transcription of SIM19 gene, which encodes aromatase. Aromatase is the enzyme that converts androgen to estrogen. So adipose tissue inflammation can stimulate estrogen biosynthesis in neighboring cells and therefore increase the risk of breast cancer. This picture depicts what is happening locally, and I wonder whether systemic increase in PGE-2 can be also influence the breast cancer risk. And urinary PGE-M, which is urinary levels of a major metabolite of PGE-2, has been generally accepted as a good measure of systemic synthesis of PGE-2. So we examined the urinary level of PGE-M and risk of breast cancer in postmenopausal women in the sister study. So sister study is a prospective study of environmental and genetic risk factors for breast cancer and other endpoints. The cohort includes over 50,000 women who have a sister with breast cancer, but they don't have breast cancer themselves at the time of study enrollment. Study participants are volunteers recruited from all over the United States between 2004 and 2009. And at the time of enrollment, participants provided information on their lifetime exposure as well as biospecimens including urine. To efficiently address the study question, we restricted our study population to postmenopausal women aged 50 years or older and who didn't report the current use of hormone replacement therapy. And about 11,000 women met this criteria, and among those, about 332 women developed breast cancer since their enrollment in the sister study. And we selected age-matched control as a comparison group, which we called the cohort women. And in the final analysis include about 310 breast cancer cases and about the same number of cohort women, subcohort women. Urinary levels of PGE-M was determined by the method called liquid chromatography tandem mass spectrometry. About 20 urine samples were analyzed in a single batch, and about 20% of total samples were analyzed in duplicate. And for the samples analyzed within the same batch, coefficient of variation was about 6% within batch, but between batch it was about 14%. And urinary levels of PGE-M was normalized to urinary levels of creatinine to control for the variation in urine concentration. In addition to our proposed analysis, we also analyzed the addition of 100 samples from a separate set of 12 postmenopausal women who provide urine samples at 3 different time points across the 9 months. And by doing this analysis, we estimated the reliability of a single-time measurement of urinary PGE-M. And our analysis showed that about 64% of the total variability were explained by between individual variability, which means a single measure of urinary PGE-M is a good representation of that individual's value, at least for 9 months or so. Here's the characteristics of participants included in our case cohort analysis. Mean age was about 61 years old, and more than 90% of the study participants were white. And compared to subcohort, with our comparison group, breast cancer cases had tended to have additional member of family history with breast cancer. For other characteristics such as menopause or age and menarche or use of NSAIDs and BMI and smoking, there are not much difference between cases and control groups. We first examined the urinary levels of PGE-M in relation to potential anti- and pro-inflammatory factors that may affect breast cancer risk. In general, lifetime use of non-steroidal anti-inflammatory drugs such as aspirin or ibuprofen were inversely associated with the urinary levels of PGE-M. But if you look at individual type of non-steroidal anti-inflammatory drugs, no clear linear relationship was found. But if you use the NSAIDs in the past 24 hours of the urine collection, you had the lower levels of urinary PGE-M. On the other hand, BMI was associated with increased levels of urinary PGE-M. We also look at other measures of obesity, such as the central adiposity measures like hip circumference, waist circumference, or waist-to-hip ratio, and we found the same positive relationship between obesity measures and urinary levels of PGE-M. And if you're a current smoker, your levels of PGE-M was also very high compared to non-smoker or past smokers. And although slight increase, high intake with saturated fatty acids was also positively associated with urinary levels of PGE-M, and as well as poor self-reported health status. We also evaluated potential anti-inflammatory factors such as physical activity as well as omega-3 fatty acids intake and vitamin E, but we did not find a clear relationship with the urinary levels of PGE-M. We then examined the association between quartiles of urinary PGE-M and postmenopausal breast cancer in our study. Overall, there is no significant association between urinary PGE-M and breast cancer risk in postmenopausal women. But once stratified by regular use of non-steroidal anti-inflammatory drugs, we started to find that high levels of urinary PGE-M was associated with more than 2 times increased risk of breast cancer in our sample. But there is no clear association in women who use the NSAIDs regularly. In the previous slide, I've shown that not just a lifetime use of NSAIDs, but also use of NSAIDs in the past 24 hours was also associated with reduced levels of urinary PGE-M. So we did an additional analysis by excluding those women in our analysis and found the same conclusion. So in conclusion, to summarize, several factors like current smoking, obesity, and high saturated fat diet and NSAIDs were found with significant correlates of urinary levels of PGE-M. And we also found that high levels of urinary PGE-M was associated with increased risk of breast cancer among postmenopausal women who did not regularly use NSAIDs. And when we published this study, there is no publication replicating our finding in breast cancer, but there have been studies of urinary PGE-M with the lung, gastric, or colorectal cancer. So putting this together, there was a commentary article that accompanied our manuscript suggesting that urinary PGE-M may be a promising cancer biomarker. With that, we decided to further identify other modifiable factors that may affect urinary levels of PGE-M. And there has been convincing evidence suggesting that fruit and vegetable intake can reduce the cancer risk, and the anti-carcinogenic effect of a fruit and vegetable may be related to its anti-inflammatory effects. And studies have shown that women or adults with high levels of fruits and vegetable intake have lower levels of C-reactive protein. But compared to C-reactive protein, COX-2 or PGE2 pathway may be more relevant for cancer and fruit intake link. So we decided to look at urinary levels of PGE-M in relation to fruit and vegetable intake in our data. This ancillary analysis was possible because the sister study has collected the information on diet at the baseline. This is a snapshot of the questionnaire used in the sister study. And this is the instruction given to the study participants. As it instructed, participants were asked about the usual dietary habits in the past 12 months or so. And for each food item, they were asked about the frequency of their eating as well as portion size. And I'm not showing here, but there is a visual aid to accurately estimate their portion size. In the questionnaire for the vegetable items, there are 23 questions, and there were 10 fruit items and 6 juice items. And not just eating frequency, we also did a nutrient analysis by assigning nutrient values to each food items and summing across all the food. And you may see that food intake was inversely associated with urinary PGE-M. So after adjustment for age and all those factors that we have identified related to urinary PGE-M, the urinary PGE-M levels were still lower in high food intake group with about 4.8, but it was increased to about 5.8 in the low food intake group. But we didn't find any relationship between vegetable intake and urinary PGE-M. This lack of the association with the urinary PGE-M and vegetable intake may be related to low antioxidant capacity of some of the vegetables most commonly consumed in our study population, which was iceberg lettuce and potatoes. We now then evaluated whether the observed relationship between food intake and urinary PGE-M can be attributed to specific nutrient rich in fruits. And indeed, fruit intake was significantly correlated with multiple nutrients we examined, and most highly correlated were vitamin C and fiber. As you can see, vitamin C and fiber are also plentiful in vegetable intake, so we look at the correlation after adjustment for vegetable intake using the statistical methods called partial correlation. Some of the nutrients like lutein and zeaxanthin, its correlation to food intake largely disappeared after adjustment for vegetable intake. But for vitamin C and fiber, its correlation with fruits and vegetables remained strong even after consideration of vegetable intake. So we examined the vitamin C and fiber intake in relation to urinary PGE-M. In our study population, more than 75% of study participants reported taking vitamin supplements that include vitamin C. So we assessed not just the dietary sources vitamin C, but also total vitamin C that combines vitamin C from different sources. And you may see that urinary levels of PGE-M was lower in high intake of vitamin C compared to low intake of vitamin C group. But after controlling for other correlates of PGE-M and dietary factors, the relationship between vitamin C and PGE-M, although still in the direction as expected, but not significant anymore. Likewise, dietary fiber was not associated with urinary levels of PGE-M significantly. Because in our previous analysis, we observed that urinary levels of urinary PGE-M was positively associated with the high intake of saturated fat, but inversely associated with the fruit intake, even after adjustment for high saturated fat intake. We decided to look at the impact of overall healthy diet on urinary levels of PGE-M. Healthy eating index is an indicator of a diet quality based on various aspects of a diet. That includes 4 components in the nutrients and 5 components from the food groups, and also measure of variety in food intake. And each component score can range from 0 to 10 with a maximum possible score of 100. And listed here is the criteria to receive the best possible score for each component. And according to the composite score, the diet quality can be categorized into good or need improvement or poor. In our sample of postmenopausal women, majority of women fall into the diet quality that needs improvement, and only 15% of women made it into good category. But if you you made into good category, your urinary levels of PGE-M was low as 4.5. And with the poor quality diet, the urinary PGE-M increased to more than 6. And this effect size is slightly greater compared to when the effect was associated with a single component alone. So to summarize, urinary levels of PGE-M was associated with increased risk of breast cancer among postmenopausal women who did not use NSAIDs regularly, and our findings were consistent with the experimental studies showing the effect of local adipose tissue inflammation on breast cancer development and progression. The relative importance of local and systemic effects of obesity remains to be known, but obesity induces inflammation not just in breast tissue but also visceral fat tissue. So local and systemic effects are likely to be an interrelated processes. And we have also identified that high-fat diet, smoking, obesity increase was associated with high levels of urinary PGE-M, but NSAID use or food intake can be related to decreased levels of PGE-2 synthesis. Whether this increase in PGE-2 synthesis may lead to estrogen levels and further breast cancer risk remain to be known. And we recently completed the analysis of 15 estrogen and estrogen metabolites in urine, so more answers could be found in the next few months. With that, I want to wrap up my talk by discussing some of the strategies to reduce obesity-driven inflammation and its consequence on breast cancer. Weight management and weight loss is the most obvious candidate approach. And obesity is a risk factor for breast cancer, so a large proportion of cancer patients are overweight or obese at the time of diagnosis. Moreover, additional weight gain can occur during our active cancer treatment. And gradual weight loss has been proven beneficial to control risk factors for cardiovascular diseases, which accounts for more than 50% of non-cancer related deaths in cancer survivors. So current clinical guidelines suggest that safe weight loss should be achieved through a well-balanced diet that is reduced in energy density and increased physical activity tailored to the specific needs of the person being treated, which is easier said than done. But diagnosis of cancer can represent a teachable moment. Several studies have shown that cancer survivors spontaneously adopt lifestyle changes in hope of achieving improved health. But the bad news is its effect doesn't seem to sustain. According to National Health Interview Survey, there are no differences in health behaviors between individuals with or without history of cancer, and approximately 70% of long-term breast cancer survivors are overweight or obese, which is the prevalence is almost about the same as the national prevalence in adult women. But there is still great interest in health promotion among cancer survivors. So cancer survivorship can provide an ideal time of window to provide lifestyle interventions. Here I'm showing this results from selected lifestyle intervention strategies targeting weight loss or weight management in breast cancer survivors. And overall, there is some general success, and there is a greater improvement in weight loss or weight management when intervention was given involves multimodal approaches. For example, early study by Lopringe focused on caloric restriction without promoting physical activity, and they found negligible differences in between intervention and control arm. But more recent studies involve diet, physical activity, and also behavior therapy, and found a greater success in finding difference in body fat as well as some of the inflammatory biomarkers and sexual hormones. But there are much to be learned at this point, and many studies are currently ongoing. In my recent search of clinicaltrials.gov, more than 6 lifestyle intervention studies were open and being currently conducted, targeting breast cancer patients or survivors. And its endpoints not only include change in BMI, but also start to look at long-term risk of recurrence and as well as the overall health effect. And intervention strategies become more creative, so it involves cognitive behavioral therapy and even include gourmet cooking workshop. So in the next few years, it is expected that we'll learn more about the effective intervention strategies and its overall effect on breast cancer recurrence as well as overall health. An alternative strategy could be pharmacological agents that target key components of dysregulated inflammatory signaling. Non-steroidal anti-inflammatory drug NSAIDs such as aspirin or ibuprofen has been associated with reduced risk of many cancers, particularly colorectal cancer. For breast cancer, there has been evidence suggesting modest risk reduction of breast cancer in relation to NSAIDs, particularly risk of metastatic breast cancer at the time of diagnosis. But at this point, because of all the risk involved in NSAIDs is not currently recommended as a cancer prevention agent. Omega-3 fatty acids, which is a particularly long-chain polyunsaturated fatty acids like DHA or EPA, have a similar effect like NSAIDs. It inhibits the inflammation pathway. But in terms of epidemiological evidence has been equivocal. But interestingly, a recent study has found that omega-3 fatty acids was associated with reduced risk of breast cancer selectively in obese women. So it may be possible omega-3 fatty acids or NSAIDs may have some particular utility to prevent obesity-driven inflammation and breast cancer risk in overweight or obese women. And lastly, metformin has been receiving a great attention as an anti-cancer agent. It is a drug prescribed to treat type 2 diabetes. And several retrospective studies found that metformin use is related to reduced risk of cancer. But there is no evidence from prospective studies yet. And based on some preliminary data, there's several clinical trials going on. And one of the studies is about whether metformin is improve the disease-free survival in patients with early stage breast cancer. And another trial involves whether metformin improves the breast density, which is a risk marker for breast cancer among overweight or obese premenopausal women. So we'll also learn more about this issue in the next few years. So with that, I'd like to acknowledge my collaborators at NIHS and Vanderbilt, and also my students who helped the data analysis as well as literature review. And lastly, most of my work related to PGE-M and diet comes from the sister study. So without their devotion, none of this my work was possible. And thank you. I can accept your question.